Approach to a patient with memory concerns. A 72-year-old male presents to the clinic because of a 1-year history of slowly progressive memory loss, reported by his wife. She states that he frequently forgets recent conversations, has missed a few appointments, and misplaces items. He asks the same questions and says the same statements repetitively. He has difficulty finding words in conversations and has gotten lost while driving on familiar routes. His wife has noticed mild irritability, but no depression or anxiety. Insidious progressive memory loss is a common symptom among older adults and a key feature of cognitive disorders. However, not all cases indicate the presence of a neurodegenerative condition. It is also important to be aware that individuals may describe their experience as memory loss when deficits arise from other cognitive domains, such as in executive function or language. By conducting a thorough assessment, clinicians can properly identify subtle changes, provide an accurate diagnosis, and implement effective interventions. Evaluating slowly progressive memory loss requires determining whether its cause is reversible or irreversible. The initial step is to obtain a detailed medical history, focusing on the onset, frequency, and progression of symptoms. Clinicians should inquire about missed appointments, repetitive questioning, difficulty finding words, deficits in comprehension, difficulty with time relationships, trouble with directions, and shifts in social behavior. Assessing functional status through basic and instrumental activities of daily living is essential for clinical staging. Reviewing current medications is imperative, as polypharmacy and anticholinergic drugs may cause or contribute to cognitive difficulties. Family history of neurological disorders, history of traumatic brain injury, sleep disturbances, and sensory deficits like hearing or visual loss can provide further insights into differential diagnosis and provide opportunities for treatment of comorbidities. Associated neuropsychiatric symptoms, including depression, anxiety, hallucinations, or apathy, may affect cognitive performance or signal certain etiologies. Lastly, clinicians should review lifestyle factors such as smoking, alcohol use, and substance intake. A comprehensive physical and neurological examination may suggest the underlying etiology. Additional workup should include brain imaging, preferably with MRI, and laboratory tests, including complete blood count, complete metabolic panel, thyroid stimulating hormone, vitamin B12 levels, and other blood work depending on the risk. MRI with contrast or other labs may be ordered based on clinical suspicion. The Montreal Cognitive Assessment, MoCA, Mini Mental State Examination, MMSE, and St. Louis Universal Mental Status, SLUMS exam, are standardized assessments to screen for cognitive dysfunction. In mild cognitive impairment, MCI, and dementia, patients have objective evidence of cognitive decline. However, those with MCI are still able to complete activities of daily living independently, while in dementia, cognitive changes are severe enough to interfere with them. Differential diagnosis of progressive cognitive decline includes neurodegenerative diseases such as Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies. Cerebrovascular disease, normal pressure hydrocephalus, psychiatric disorders, medication side effects, metabolic imbalances, and structural lesions. Given the availability of FDA-approved medications that slow down the progression of disease for patients with MCI and mild dementia due to Alzheimer's disease, biomarker testing such as amyloid PET scan and CSF analysis for Alzheimer's disease should be considered in the appropriate clinical setting. Our patient was ultimately found to have Alzheimer's disease, the most common cause of dementia. Early detection of cognitive decline and an accurate diagnosis facilitates timely intervention, improves patient outcomes, and decreases care partner burden. Management of patients with cognitive disorders starts with treatment of the underlying etiology, followed by management of clinical and psychiatric comorbidities, deprescribing whenever possible, lifestyle changes, care partner support and education, and referral to community resources. For more information on this and other neurologic conditions, please visit aan.com/neurobytes.